Have you ever found yourself just staring at maybe a complex medical report or, digging into research for a big presentation and feeling totally overwhelmed? Like you really want to get it to master it, but it's just a lot.
Yeah, I think we've all been there.
Well, you're definitely in the right place today
Oh,
because we're taking a really deep dive into a vital and actually pretty common area of medicine, cardiac arrhythmias, and the pharmacology behind treating them.
that's right. We've got quite a stack of detailed sources here, including some hefty excerpts from KATZUNG's basic and clinical pharmacology. And our mission today isn't just scratching the surface.
No way.
We're aiming to unpack everything. I mean, from the basic electrical pulses in the heart all the way to the specific drugs used for abnormal rhythms. We're going deep, covering really every concept in detail here so you can truly master this stuff.
Exactly. And for you listening, whether you're just curious about heart health, maybe prepping for a discussion with your doctor, or you genuinely want that, elite professional level understanding, this deep dive is designed for that.
We're going to break down some pretty complex things. Ion channels, action potentials, drug classes, into hopefully clear and memorable insights.
Think of it as getting you past just knowing the facts to really understanding the why and the how. Why arrhythmias happen, how the drugs work at a cellular level. So let's start peeling back these layers.
Okay, so let's start with the problem itself. Cardiac arrhythmias. Just how common are they? Well, our sources show they can pop up in up to 25% of patients on digitalis.
Wow, a quarter.
Yeah, and maybe 50% in anesthetized patients and even over 80% in folks having an acute heart attack.
That's huge.
It really is. And these aren't just, minor blips, rhythms that are too fast, too slow, or just out of sync. They can seriously reduce how effectively the heart pumps blood, what we call cardiac output.
And some can be really dangerous, right?
Absolutely. Some, like certain premature ventricular beats, can even trigger lethal problems like ventricular fibrillation.
Okay, that highlights the danger. But what's tricky, almost paradoxical, is the treatment itself, isn't it?
That's a crucial point. The very drugs we use to fix arrhythmias can sometimes, unfortunately, cause new, potentially deadly ones. It's this inherent risk.
So clinicians are always doing this balancing act, risk versus benefit.
Constantly. Which is why, generally speaking, if an arrhythmia isn't causing any symptoms, or very minimal ones, the approach is often to avoid drug treatment. The risk might just outweigh the benefit.
And it's not just about drugs, is it? There are other approaches.
Right. Important to mention the non-pharmacologic options. Things like pacemakers for slow rhythms, or cardioversion, the electric shock, or even catheter ablation for fast ones. Sometimes surgery is needed too. But today, our focus is squarely on the direct-acting drugs.
Got it. So let's dive into the heart's normal electrical symphony. How does it usually work? Where does it all start?
It all begins with the maestro, the sinoatrial node, or SA node. It's this tiny group of cells that normally fires off the electrical impulse, usually at a steady 60 to 100 beats per minute.
Okay, the natural pacemaker.
Exactly. This signal then spreads really quickly across the upper chambers, the atria. Then it hits the atrioventricular node, the AV node.
And that's like a gatekeeper, right?
Precisely. It's the only normal electrical pathway between the atria and the ventricles. And conduction through the AV mode is deliberately slow, takes about 0.15 seconds.
Why the delay?
It's vital. That little pause gives the atria just enough time to finish contracting and push blood down into the ventricles before the ventricles themselves get the signal to contract. Perfect timing.
Okay, so after that brief pause at the AV node,
Then the impulse zooms down the His-Purkinje system. It spreads super rapidly throughout the ventricles. The whole activation takes less than 1/10 of a second.
wow, fast.
Yeah, and that speed ensures that the ventricles contract in a really coordinated, synchronous way. A powerful, efficient pump.
So arrhythmias are basically any deviation from that normal sequence.
Pretty much. They arise from problems in either how the electrical impulse is formed in the first place or how it's conducted, how it travels through the heart.
To really get this, I guess we need to go even deeper down to the cellular level, the ions.
Exactly. To truly master this, you have to understand the ionic basis. The electrical activity of every single heart cell depends on the uneven distribution of key ions across its membrane. We're talking mainly sodium, Na+, potassium, K+, calcium, Ca2+, and chloride, Kl.
And how does the cell keep these ions unbalanced? That seems important.
It is. The major player is the sodium-potassium ATPase, or the sodium pump. Think of it working constantly in the background.
What does it do?
It pumps sodium out of the cell and potassium into the cell. This keeps intracellular sodium low and intracellular potassium high. It's fundamental.
Okay, and our sources talk about equilibrium potential. What's that?
Right, E-ion. For any given ion, that's the specific electrical voltage across the membrane that would perfectly balance its tendency to move down its concentration gradient. Like for potassium, it's around 90 millivolts. For sodium, it's way up at plus 70 millivolts.
So the actual movement depends on the difference between the cell's voltage and that specific ion's equilibrium potential.
Exactly. That difference is the electrochemical gradient, or driving force. It dictates which way the ion wants to move and how strongly.
And ions don't just leak across, right? They use channels.
Correct. They move through specific protein structures called ion channels. You can picture them as tiny selective pores or tunnels.
And they have gates.
Yep. Most of the important ones for the action potential have voltage-sensitive gates. They open or close depending on the membrane voltage. Some are ligand-gated, opened by chemicals. And their activity can be tweaked, by ion levels, cell metabolism, internal signals. It's complex.
What about transporters? The source mentioned the sodium-calcium exchanger, NCX.
Ah, good point. Some transporters are electrogenic, meaning they move an unequal amount of charge. NCX typically kicks one calcium ion out for every 3 sodium ions it brings in.
So that creates a net inward current.
Right, a small depolarizing current. Normally not huge, but if calcium spontaneously leaks inside the cell, it can activate NCX more strongly. This contributes to normal pacemaker activity, but also it can cause those problematic delayed after depolarizations, or DADs, which can trigger arrhythmias, a small nudge that can become a big problem.
Okay, that cellular basis is key. Now let's walk through the action potential itself, that electrical wave. Starting with the main pumping cells, atrial and ventricular, the fast responders.
Right, so phase 4 is their resting state, diastole. It's very stable, mostly thanks to an inward rectifying potassium current called IK1. This keeps the membrane potential down near potassium's equilibrium potential, around negative 90 milliVs.
So it's very sensitive to potassium levels outside the cell.
Extremely. Small changes in extracellular potassium can significantly shift that resting potential. It highlights how crucial electrolyte balance is.
Okay, phase 4 is rest. What kicks it off? Phase 0.
Phase 0 is the big upstroke. It's super rapid depolarization caused by a sudden massive influx of sodium ions through voltage-gated sodium channels, IM.
These channels have different states, right? Resting, activated, inactivated, with M and H gates.
Exactly. When the stimulus arrives, the activation edge gates fly open almost instantly. Sodium rushes in, driving the voltage way up towards sodium's equilibrium potential. But it's brief because the inactivation edge gates snap shut very quickly afterwards.
Like a quick opening and slamming shut.
Pretty much. That rapid inactivation is key. It contributes to the next phase, phase 1, which is a brief early repolarization. In some cells, this also involves a quick outward puff of potassium current called ETO.
Then comes the plateau phase, phase 2.
Yes, the plateau.
Yeah.
This is where the cell stays depolarized for a while. The main reason is the opening of slower L-type calcium channels, allowing calcium ions to trickle in. There might also be a tiny bit of lingering late sodium current, INL.
And this plateau is important for
sustaining the muscle contraction. It keeps the cell on for longer.
Okay, and finally, how does it get back to resting? Phase 3.
Phase 3 is the final repolarization. Here, the calcium channels inactivate, and potassium channels really open up, letting potassium ions rush out of the cell. The key players here are the delayed rectifier potassium currents, a rapid one, IKR, and a slow one, IKs, plus that resting IK1 current helps too.
And atrial cells are a bit different.
Yeah, they have some extra potassium currents like the ultra-rapid IKER and an acetylcholine-sensitive one, IKAC, which help them repolarize a bit faster than ventricular cells.
So those are the fast responders. What about the self-starters, the pacemaker cells, like Purkinje fibers?
Right. Purkinje cells are interesting. They have a fast, sodium-driven upstroke like the muscle cells. But what's unique is their ability to spontaneously depolarize during phase 4.
How do they do that?
Primarily through special channels carrying the funny current, IF. These channels are weird. They actually get activated by hyperpolarization when the cell is most negative. This allows a slow leak of positive ions in, gradually raising the voltage.
So they can potentially take over pacing if needed.
Exactly. They're latent pacemakers, especially if things like low potassium make them more excitable.
And the main pacemaker, the SA node.
The SA node also uses that funny current IF and the sodium-calcium exchanger for its spontaneous phase 4 depolarization. But here's a key difference. Its action potential upstroke, phase 0, is primarily driven by calcium influx, not sodium.
so it's slower.
Much slower velocity compared to the sodium-driven upstrokes. And the AV node is similar, also a slow, calcium-dependent upstroke. That inherent slowness is exactly why the AV node creates that crucial conduction delay we talked about.
And the nervous system can tweak all this, sympathetic versus parasympathetic.
Absolutely. Think sympathetic, like adrenaline, as the accelerator via beta receptors. It speeds up heart rate, enhances calcium current, speeds conduction. Parasympathetic, like acetylcholine, is the brake via muscarinic receptors. It slows the SA node, slows AV conduction, mainly by increasing potassium conductance.
Okay, this leads to a really important concept. How does the cell's electrical state affect its excitability? And how do drugs play into that?
Right. During that plateau phase, in the fast response cells, most sodium channels are stuck in the inactivated state. The H gates are closed. This means the cell is refractory. It can't easily fire again.
It needs time to reset.
Exactly. Recovery from inactivation, the H gates reopening, takes time and depends on the voltage getting back down towards resting levels. The duration needed for enough channels to recover is the refractory period.
And drugs can mess with this recovery.
Precisely. This is where that use dependence idea comes back. Sodium channel blockers, for instance, can bind preferentially to the inactivated channels and slow down the recovery. This makes the cell less excitable and slows conduction, especially at faster heart rates when channels spend more time inactivated.
So they target the misbehaving cells more.
That's the goal. And for the SA and AV nodes, which rely on calcium channel blockers work similarly. They slow down pacemaker activity and conduction by interfering with calcium influx.
Okay, now we understand the normal process and the basics of drug action. Let's switch gears to what actually causes arrhythmias. What triggers them?
A whole host of things, unfortunately. The big ones are ischemia, lack of blood flow, hypoxia, lack of oxygen acidosis or alkalosis, electrolyte imbalances, especially potassium and magnesium.
You mentioned those are critical.
Yeah, absolutely. Also, too many stress hormones, catecholamines, funky autonomic nervous system signals, drug toxicity, including antiarrhythmics themselves, ironically, even physical things like overstretching the heart muscle or just having scarred, diseased tissue can set the stage.
But fundamentally, it boils down to two main problems, right?
It's either a problem with impulse formation, the signal starts wrong, or impulse conduction, the signal travels wrong.
Let's tackle impulse formation first. Abnormal pacemaking.
Yeah, beyond just the nervous system effects, sometimes there are genetic mutations that directly mess with the normal pacemaker channels. And remember those latent pacemakers, like Purkinje fibers? Under stress, like low potassium, they can get overly active and start firing inappropriately.
And then there are these after depolarizations you mentioned earlier, triggered events.
Exactly. These are abnormal depolarizations that happen during or just after a normal action potential. First, you have early after depolarizations, or EADs.
When do they happen?
During phase 3, while the cell is trying to repolarize, they're often caused by things that prolong the action potential duration, making phase 3 take too long.
Like in long QT syndrome.
Precisely. Whether it's congenital or drug-induced, often by blocking that IKR potassium current. EADs are worse with low potassium and slow heart rates. They're dangerous because they can trigger repetitive firing.
And the other type, DDs.
Delayed after depolarizations. These happen after repolarization is complete, during phase 4. They're usually linked to calcium overload inside the cell.
What causes calcium overload?
Things like digitalis toxicity, excessive catecholamine stimulation like intense stress, or myocardial ischemia can all lead to too much calcium inside, triggering these DADs.
This seems like a good place to dive into the genetics, the ion channelopathies.
Absolutely. This is where we see the direct link between faulty ion channels and specific arrhythmia syndromes. A prime example is torsades de pointes.
That sounds dramatic.
It looks dramatic on an ECG too, a polymorphic ventricular tachycardia. It's associated with that prolonged QT interval we mentioned and can cause fainting or sudden death. The prolonged action potential allows those EADs to pop up and trigger this chaotic rhythm.
And we know the specific genes involved in things like congenital long QT syndrome.
We do, and it's fascinating. Over 1,400 mutations in at least 15 different ion channel genes. Often it's loss of function in potassium channels like KCNH2, which codes for IKR, or KCNQ1, IKs. Less potassium current flowing out means repolarization takes longer.
Or it could be the opposite, gain of function.
Right. Gain of function in sodium channels, SCN5A, or calcium channels, CAKNA1C, means too much inward current during the plateau, also prolonging the action potential.
And knowing the specific mutation helps guide therapy. That's amazing.
It's the foundation of personalized medicine in this field. For instance, LQT3, caused by a sodium channel gain of function, might respond well to a sodium channel blocker like bexalotine. LQT1 from KCNQ1 loss of function is often treated with beta blockers because it's sensitive to adrenergic stimulation.
Wow. Are there other genetic syndromes linked to ion channels?
Oh yeah. Short QT syndrome, the opposite problem. Action potential is too short. Often involves gain-of-function potassium channel mutations. There's CPVT, catecholaminergic polymorphic ventricular tachycardia linked to abnormal calcium handling genes, sick sinus syndrome, Brugada syndrome, progressive cardiac conduction disorder. They often involve mutations in sodium channel genes like SCN5A. Even some forms of familial atrial fibrillation are linked to potassium channel mutations.
It really highlights how critical these tiny channels are. Okay, that covers impulse formation. What about the other main problem? Abnormal impulse conduction.
The classic example here is art block, usually occurring at the AV node. It can range from just a slowdown, a longer PR interval on the ECG, all the way to complete heart block, where no signals get through from atria to ventricles.
What happens then?
Either a lower pacemaker site, like in the ventricles, takes over with a slow escape rhythm, or the patient needs an artificial pacemaker. Sometimes, if the block is due to high vagal tone, parasympathetic activity, a drug like atropine can help by blocking that effect.
But the really complex conduction problem is reentry, right? The circus movement.
Yes, reentry is responsible for the majority of clinically important arrhythmias. It's essentially an electrical signal getting stuck in a loop, re-exciting tissue it already passed through.
Like an electrical short circuit.
Kinda. It can cause anything from single extra beats to sustained fast rhythms like supraventricular tachycardia or ventricular tachycardia, or even complete chaos like atrial or ventricular fibrillation, where you'd have multiple reentry wavelets swirling around.
Is there a classic example?
Wolff-Parkinson-White syndrome is a great anatomical example. Patients have an extra electrical connection, an accessory pathway that forms part of the reentry circuit.
What conditions are needed for reentry to actually happen? The sources mention 3 key things.
Yes, this is crucial for understanding it. First, you need an obstacle, some kind of anatomical barrier, or even just an area of functionally dead tissue around which the signal can circulate.
Okay, a pathway.
Second, you need unidirectional block somewhere in that pathway. The impulse has to be blocked going one way, but able to go the other way around the obstacle.
How does that happen?
Ischemia is a common cause. Lack of blood flow leads to higher extracellular potassium, which partially depolarizes cells. This slows down sodium channel recovery, making the tissue refractory for longer, potentially blocking conduction in one direction while still allowing slower conduction in the other.
Okay, obstacle, one-way block. What's the third piece?
The conduction time around the loop has to be longer than the refractory period of the tissue at the site of the block. So by the time the impulse gets back around to where it was initially blocked, that tissue has recovered and is ready to be stimulated again, completing the loop.
And the cycle just repeats.
Exactly. Loop after loop, causing a tachycardia.
So how do antiarrhythmic drugs stop reentry?
2 main ways. One is to worsen the block. Drugs that block sodium or calcium channels can slow conduction even more, hopefully converting that unidirectional block into a bidirectional block. If the signal can't go either way, the circuit dies.
Makes sense. What's the other way?
You can increase the refractory period. Drugs that prolong the action potential duration, usually by blocking potassium channels, make the tissue stay refractory longer. If the refractory period becomes longer than the time it takes the signal to circle back, the returning impulse hits tissue that's still recovering and can't be excited. Again, the circuit dies.
Okay, that clarifies the mechanisms. Now let's get into the drugs themselves, a pharmacological arsenal. What are the main goals again?
Broadly, 2 things. Reduce that abnormal ectopic pacemaker firing and modify conduction or refractoriness in those reentry circuits to shut them down.
And they achieve this through 4 main mechanisms.
Generally, yes. 1, sodium channel blockade. 2, blocking the sympathetic nervous system effects, usually with beta blockers. 3, prolonging the effective refractory period, typically by blocking potassium channels. And 4, calcium channel blockade.
You mentioned that use dependence or state dependence concept earlier. Can we revisit that? It seems critical for understanding how these drugs work selectively.
Absolutely fundamental. The most useful channel blockers bind better to channels that are either open, activated, or inactivated, compared to channels that are just sitting there in the resting state.
Why is that important?
Because cells that are firing too rapidly during a tachycardia, or cells that are partially depolarized due to disease, spend more time with their channels in the activated or inactivated states. So the drug preferentially targets these abnormal, misbehaving cells.
While leaving normal, resting cells relatively untouched.
Ideally, yes, at therapeutic doses. It allows for selectivity, but it's a double-edged sword. Push the dose too high, and you start affecting normal tissue too, which is how you get drug-induced arrhythmias, the prorhythmic effect.
Okay. To help organize all these drugs, we use the Singh-von Williams classification, right? The 4 classes.
Yes, it's the classic framework. It's not perfect. Some drugs have multiple actions, but it's incredibly useful for grouping drugs with similar primary mechanisms and predicting likely side effects.
Let's start with class 1, sodium channel blockers. They're subdivided.
Right. Based on their effect on action, potential duration, APD, and how quickly they dissociate or unbind from the sodium channel.
Class 1A, like procainamide.
Class 1 agents,
Well, yeah.
procainamide, quinidine, disopyramide, they tend to prolong the APD and have intermediate dissociation kinetics. Procainamide slows that phasio upstroke, slows conduction velocity, and widens the QRS complex on the ECG. It also blocks some potassium channels, which contributes to prolonging the APD.
What are the downsides? Toxicity.
It can cause excessive QT prolongation and trigger torsades de points, and long-term use is famous for causing a reversible lupus-like syndrome in about a third of patients. GI upset is common too, and rarely serious blood problems like a granulocytosis.
And it has an active metabolite?
Yes, NAPA, N-acetylprocainamide. It actually has significant class 3 activity potassium channel block and can contribute to torsades, especially if kidney function is poor, because both the drug and NAPA are cleared by the kidneys. Procainamide itself is now only IV in the U.S.
What about quinidine and disopyramide in this class?
Quinidine is similar, but generally considered more toxic. Causes synconism, headache, dizziness, tinnitus, plus lots of GI issues, and can cause low platelets and torsades. Rarely used now. Disopyramide has strong antimuscarinic side effects, dry mouth, urinary retention, blurred vision, plus it can worsen heart failure due to its negative inotropic effect. Definitely avoid it in heart failure patients.
Okay, moving to class 1B, lidocaine and mexiletine. How are they different?
Big difference. They have little effect on APD, might even shorten it slightly, and they dissociate very rapidly from the sodium channel. Lidocaine, given IV, is a great example of use dependence. It blocks activated and inactivated channels, but because it unbinds so quickly during diastole when channels are resting, it has minimal effect on normal tissue and normal heart rates.
But it hits diseased tissue harder.
Exactly.
Yeah.
In depolarized ischemic cells, channels recover more slowly from inactivation, so lidocaine sticks better and selectively suppresses conduction in those areas. This makes it one of the least cardiotoxic sodium channel blockers overall.
So its side effects aren't usually cardiac.
More often neurological,
Yeah.
especially at higher doses, things like tingling, tremors, dizziness, even seizures. It's rapidly metabolized by the liver, so IV only, and you need dose adjustments in liver disease or heart failure.
What's its main use?
It's the drug of choice for terminating VT and preventing VF after a heart attack during acute ischemia. But, and this is critical routine prophylactic use in all MI patients, actually increased mortality in trials. So targeted use only.
And mexiletine.
Basically an oral version of lidocaine. Similar actions.
Yeah.
Used for ventricular arrhythmias and sometimes off-label for neuropathic pain.
Okay, last subgroup, class 1C, flecainide and propafenone, slow dissociation.
Very slow dissociation kinetics, and they don't significantly prolong the APD. Flecainide is a potent sodium channel blocker, also blocks some potassium channels. It's very effective for suppressing supraventricular arrhythmias like AFib, and primarily in patients without structural heart disease.
And this leads us to that crucial trial, KEYST.
Yes, the Cardiac Arrhythmia Suppression Trial, a landmark study. It tested class 1C drugs, like flecainide, to suppress PVCs after a heart attack, thinking that would reduce mortality. The result was shocking.
What did it show?
A 2.5-fold increase in mortality in the patients getting the class 1C drugs compared to placebo. It dramatically highlighted the risk of prorhythmia, especially in patients with underlying ischemic heart disease. It fundamentally changed how we use these drugs.
A huge lesson learned. What about propafenone?
Similar sodium channel blocking to flecainide, but it also has some rank beta blocking activity. Also used mainly for supraventricular arrhythmias, again, typically avoiding patients with significant structural heart disease.
Okay, that covers class 1. Let's move to class 2, the beta blockers.
Like propranolol, metoprolol, their main antiarrhythmic action is reducing sympathetic stimulation of the heart. They slow down the SA node rate and AV node conduction.
Are they good at suppressing ventricular arrhythmias directly?
Less so than class 1 drugs in terms of just reducing ectopic beats. But, and this is incredibly important, beta blockers are the only class proven to reduce mortality and sudden death after a myocardial infarction. Their protective effect is profound, even if they don't eliminate every extra beat. Esmolol is a short-acting IV-1 used acutely. Sudolol is special as it also has class 3 properties.
Perfect segue to class 3. Drugs that prolong the effective refractory period, usually by blocking potassium channels.
Right. Their main goal is to prolong the action potential duration. This increases the refractory period, making the tissue less excitable, which is good for stopping re-entry.
But you mentioned a potential downside earlier, reverse use dependence.
Yes, this is a really undesirable property of many class 3 drugs. They tend to prolong the APD most at slow heart rates, and least at fast heart rates.
Which is the opposite of what you'd want.
Exactly. You want the effects strongest when the heart is racing. This reverse use dependence significantly increases the risk of triggering torsades de pointe, especially at slower baseline heart rates. QT prolongation alone isn't the whole story. This phenomenon is key.
Now, the superstar you mentioned, amiodarone, it seems to break some rules.
It's truly unique. It has actions from all 4 classes. Its dominant effect is class 3. It potently blocks potassium channels, especially IKR, and markedly prolongs APD in the QT interval. But critically, it does this without significant reverse use dependence.
How does it manage that?
It also blocks inactivated sodium channels, class 1B-like, has weak beta blocking effects, class 2, and some calcium channel blocking effects, class 4. This complex profile makes it highly effective for a wide range of arrhythmias, both atrial and ventricular, and surprisingly, it has a relatively low risk of causing torsades despite the significant QT prolongation.
But it comes with a lot of baggage, right? Side effects.
Oh, yes. It accumulates extensively in tissues all over the body, lungs, liver, skin, eyes. The biggest concern is dose-related pulmonary toxicity, which can lead to fatal fibrosis in about 1% of patients.
What else?
Liver toxicity, photosensitivity, bad sunburns, a strange gray-blue skin discoloration, deposits in the cornea causing visual halos, optic nerve problems, and importantly, because it contains iodine, it has major effects on the thyroid, causing either under- or overactivity.
And its pharmacokinetics are tricky.
Incredibly complex, variable absorption, very slow elimination, with a half-life measured in weeks to months. Its effects linger long after stopping it. Plus, it inhibits liver enzymes like CYP3A4, leading to tons of drug interactions, boosting levels of warfarin, statins, digoxin. It's very careful management.
Despite all that, it's widely used.
Yes, because it's so effective, especially for maintaining rhythm in atrial fibrillation. Crucially, unlike the class 1C drugs, it hasn't been shown to increase mortality in patients with coronary artery disease or heart failure. It's often the go-to drug in those difficult situations, and used alongside defibrillators, ICDs.
What about dronedarone, the analog designed to be safer?
It was designed without the iodine atoms to avoid the thyroid and hopefully lung issues. It does have multi-channel actions and a much shorter half-life. However, it still carries risks. Liver toxicity has been reported, and it has a major black box warning against its use in patients with decompensated heart failure or permanent atrial fibrillation, because trials showed increased risk of death, stroke, and heart failure hospitalization in those groups. So safer in some ways, riskier in others.
Sudolol, you mentioned it has class 2 and class 3 activity.
Correct. It's a beta blocker that also prolongs the APD by blocking potassium channels. Fairly straightforward pharmacokinetics, mainly kidney excretion. Its main drawback is dose-dependent torsades de pointe risk, used for series VTs and for AF rhythm control.
Dofetilide, pure class 3.
Yes, a very specific blocker of the IKR potassium current. Because the risk of torsades is directly related to drug concentration and QT interval, it must be started in the hospital with intensive ECG and electrolyte monitoring, approved for converting and maintaining sinus rhythm and AFib.
Anibutylide.
Another class 3, given IV primarily for rapid conversion of atrial flutter or recent onset AFib back to sinus rhythm. Main risk again is torsades, requiring several hours of ECG monitoring after infusion.
Okay, that's class 3. Finally, class 4, calcium channel blockers, like verapamil.
Verapamil and diltiazem are the main ones used as antiarrhythmics. They primarily block L-type calcium channels. Their effect is most pronounced in tissues that depend heavily on calcium currents, namely the SA and AV nodes.
So they slow the heart rate and conduction through the AV node.
Exactly. They prolong AV nodal conduction time and refractoriness. Very effective for slowing the ventricular rate during atrial fibrillation or flutter, and for terminating supraventricular tachycardias that involve the AV node in a reentry circuit.
What are the main concerns with verapamil?
Dose-related negative inotropic effects, it can weaken the heart's pump, so caution in heart failure. Constipation is a common side effect. And the big danger, as we mentioned, is giving IV verapamil to someone with ventricular tachycardia that's been misdiagnosed as SVT. It can cause catastrophic blood pressure collapse and VF. Adenosine is generally preferred now as first line for SVT termination because it's so short-acting.
Diltiazem is similar.
Very similar profile, and uses for supraventricular arrhythmias and rate control in AFib flutter. Maybe slightly less potent negative inotropic effect.
All right, that covers the main 4 classes. But there are some miscellaneous agents, too. The oddballs.
Definitely. Adenosine is a key one. It's a naturally occurring substance with an incredibly short half-life, like less than 10 seconds.
Wow, blink and you miss it.
Pretty much. It works by activating potassium channels and inhibiting calcium current in the AV node, essentially hyperpolarizing the cells and stopping conduction dead in its tracks for a moment. This makes it extremely effective, like 90–95% effective for terminating paroxysmal SVTs involving the AV node.
Side effects are brief, then.
Yes. Usually flushing, maybe some chest tightness or shortness of breath, sometimes a brief, scary-looking heart block, but resolves very quickly. It's the go-to drug for diagnosing and treating many SVTs.
What about ivabradine?
That's a selective blocker of the funny current, if primarily in the SA node, so it slows the heart rate directly at the source.
Without affecting pump function.
Exactly. No effect on contractility, repolarization, or AV conduction. Used mainly for chronic angina or heart failure to reduce heart rate, and sometimes for inappropriate sinus tachycardia, can cause some visual brightness disturbances.
Ranolazine. Antianginal with antiarrhythmic properties.
Right. It blocks that late sodium current, INAL, we mentioned earlier, and also some IKR. Its effects are complex, but it seems promising for suppressing both AFib and VT. Not yet officially approved as an antiarrhythmic, though.
Vernaculant.
A multi-channel blocker, but seems more potent in the atria. Used 5E in Europe for rapid conversion of recent onset AFib. Notably, it causes only mild QT prolongation and doesn't seem to cause torsades. Not available in the US yet.
And good old magnesium.
Yep. Use fee. Initially for digitalis-induced arrhythmias if magnesium levels were low. But it's also the standard treatment for torsades de pointes, even if the patient's magnesium level is normal. The exact mechanism isn't perfectly clear, but it seems to stabilize membranes and affect various ion channels.
Lastly, potassium itself.
We touched on this, but it's worth repeating. Both too much hyperkalemia and too little hypokalemia potassium are dangerous and can cause arrhythmias. Hyperkalemia depolarizes cells, slows conduction, can cause blocks. Hypokalemia hyperpolarizes but paradoxically prolongs repolarization, increasing risk of EADs and torsades. Maintaining normal potassium levels is absolutely fundamental in managing arrhythmias.
Okay, whew. That's a huge arsenal of drugs and mechanisms. Now let's bring it all together. How do clinicians actually apply all this? You said the therapeutic window is narrow.
Extremely narrow. It truly is an art, balancing efficacy against toxicity. The first step, always, is a thorough pre-treatment evaluation.
What does that involve?
Number 1, try to eliminate the cause. Is there hypoxia? An electrolyte problem. Is another drug causing this? Is it hyperthyroidism? You have to identify and fix any underlying reversible factors first.
Makes sense. What's next?
Number 2, get a firm diagnosis of the arrhythmia. You absolutely have to know what rhythm you're treating to pick the right drug and avoid disasters, like that verapamil and VT scenario. ECGs, sometimes longer monitoring, are essential.
Okay, diagnosis is key.
Number 3, assess the underlying heart condition. This is probably the most critical factor for drug selection. Does the patient have heart failure? Previous MI? Left ventricular hypertrophy? As we saw with CASCAS, drugs that are safe in a normal heart can be lethal in a diseased heart, so you need to know the substrate.
And finally?
Number 4, question the need for therapy at all, especially for asymptomatic or minimally symptomatic arrhythmias. Remember, CASCAS sometimes intervening does more harm than good. Is the goal symptom relief? Or preventing something truly dangerous like stroke or sudden death.
So it's always this risk-benefit calculation. What are the main benefits and risks again?
Benefits are primarily reducing symptoms, palpitations, dizziness, fainting, and in some specific cases, like post-MI with beta blockers, reducing mortality. Risks are varied, some dose-related, like lidocaine tremor, some idiosyncratic, like procainamide lupus. But the most serious risks, like proarrhythmia, often arise from that interaction between the drug and the patient's underlying heart disease.
And specific drugs cause specific proarrhythmia syndromes, like Torsades.
Exactly. Torsades is the classic one, linked to drugs that prolong repolarization, class 1A, class 3 agents like sotalol, tofetalide, ibutylide. Treatment is stopping the drug, fixing low potassium magnesium, maybe speeding up the heart rate temporarily and giving IV magnesium.
And the other main type, reentry.
Reentry arrhythmias can be provoked by drugs that markedly slow conduction, especially class 1C drugs or high-dose class 1A, particularly in patients with scarred hearts post-MI. Treatment is stopping the drug. Sometimes IV sodium can help reverse the block.
Let's try to apply this. Remember that hypothetical case, Sarah, the 69-year-old teacher with new AFib?
Right. She had symptoms, palpitations, shortness of breath, and importantly, impaired heart function, LVEF, of 38%. Plus, risk factors for stroke, age, female, hypertension.
So what's the thinking process?
Okay, first, stroke risk is high, so she needs lifelong anticoagulation. She was started on rivaroxaban. Second, she has symptoms and heart failure, making rhythm control a reasonable goal, not just rate control. Third, because of the heart failure, drug choice is limited.
Which drugs are generally okay in heart failure?
Primarily, amiodarone and dofetilide are considered relatively safe and effective for rhythm control in HF. Class 1C drugs are out, so tolzol might be considered carefully, but Torsade's risk is higher in HF.
And in her case, tofetilide worked.
Yes, she was started on dofetilide, likely in hospital with monitoring. Her rhythm converted, symptoms improved, and her ejection fraction even went up to 48%. Catheter ablation remains an option if drugs fail or aren't tolerated.
That really illustrates the process. Atrial fibrillation seems like a perfect example for applying these principles.
It absolutely is. It's so common. The goals are symptom relief, preventing stroke, and preventing tachycardia-induced cardiomyopathy, heart failure from prolonged rapid rates.
Is rate control or rhythm control usually preferred?
Often, especially for long-term management, rate control is the initial and sometimes primary strategy, using beta blockers, calcium channel blockers, verapamiltitiazem, or sometimes digoxin, especially if heart failure is present, to just slow the heart rate down.
Yeah.
Large trials have shown that for many patients, rate control leads to similar or even better outcomes than trying to maintain sinus rhythm with drugs with fewer side effects.
But sometimes rhythm control is necessary.
Yes, especially if symptoms persist despite good rate control, or in younger patients, or if there's concern about heart function decline. Options include electrical cardioversion or drugs like flecainide if no structural heart disease, or IV ibutylide for acute conversion.
And long-term maintenance depends heavily on underlying heart disease.
Critically, the guidelines have algorithms based on whether there's heart failure, coronary artery disease, hypertension with LVH, or none of the above. It dictates which drugs, like amiodarone, dofetilide, sotalol, or maybe flecainide are considered safer and more effective for that specific patient profile.
And anticoagulation is key.
Absolutely non-negotiable for most AFib patients based on their stroke risk score, like CHT2DS2 base goal. Plus, ablation therapy, particularly pulmonary vein isolation, is playing an increasingly large role, offering a potential cure by electrically isolating the triggers for AFib, often reflecting the desire to avoid long-term drug toxicities.
So when therapy is chosen, how is it managed? And what about combining drugs?
Urgency dictates route and speed of initiation. Plasma level monitoring can sometimes be helpful for certain drugs, especially to check compliance or manage interactions. As for combinations, it's sometimes done theoretically to use lower doses of each drug and target multiple mechanisms.
Like amiodarone plus a sodium channel blocker.
Possibly, or a class 3 plus a sodium channel blocker. But robust clinical data is often lacking, and some combinations are proven problematic, like sotalol plus quinidine had high rates of torsades. It needs extreme caution.
But there's ongoing research, like the Harmony trial.
Right. That trial looked at low-dose dronedorone plus ranolazine for paroxysmal AF. The idea was to target specific atrial electrical properties. It did show a reduction in AF burden compared to either drug alone, so there's potential for smarter, more targeted combinations in the future.
We have certainly gone deep today. We've peeled back the layers on cardiac arrhythmias, from ions dancing across membranes to the complex ways impulses can go wrong, and then explored this huge range of drugs used to try and restore harmony.
Yeah, we covered a lot. From the basic science to the mechanisms of arrhythmia, the specific drug actions, their toxicities, and how clinicians try to navigate that narrow path between helping and harming. Hopefully you, the listener, now have more than just information.
Right. You should have a much clearer understanding of the why behind arrhythmias and the how behind the treatments. That elite professional level grasp we are aiming for, you understand the challenges, the risks, the benefits.
It's a fascinating and complex field.
It really is. And thinking about it all, especially that narrow therapeutic window for drugs and how non-drug therapies like ablation are advancing, it raises a really interesting question to leave you with. What does the future hold for rhythm management? Will we see drugs become incredibly targeted, maybe based on your personal genetic code, hitting just the right faulty channel? Or will things like ablation and sophisticated devices start to overshadow drug therapy for many people, really shifting the whole approach? What new innovations might redefine how we treat arrhythmias in the years to come?
That's the provocative thought, isn't it? Where this balance between pharmacology and technology and personalized medicine will ultimately lead us. Definitely something to keep an eye on.